Welcome back to the CSP Elite Baseball Development Podcast. I'm your host, Eric Cressey, and this is episode 219. This is the grand finale of this season. We always do 10 episode seasons with this podcast over the course of the year. And I think we're going out with a bang because this is an absolutely awesome episode. These are two guys that I've referred to quite a bit over the years, seen their expertise at work with some patients that we sent their way with excellent outcomes. So it's cool to really roll back the curtain a little bit on some newer age diagnoses that we're seeing, things that we're better understanding in this world of not just baseball sports medicine, but overhead athlete sports medicine with respect to thoracic outlet syndrome and obviously peripheral nerve entrapments, which kind of go hand in hand in terms of differential diagnoses. So this is an excellent episode, one of my all-time favorites, and I think you're really going to enjoy it. This episode is brought to you by AG1, the most comprehensive NSF certified for sport daily nutritional supplement I've ever tried. With so many stressors in life, it can be difficult to maintain effective nutritional habits and give our bodies the nutrients they need to thrive. As a father of 3 young kids and a co-founder of multiple businesses in multiple states, on top of still being an avid exerciser, I know that busy schedules can really take their toll on us. Whether it's poor sleep, exercise or life stressors, environmental factors, or simply not eating enough of the right foods, we can wind up deficient nutritionally. This is where AG1 can really help. It's a game-changing nutritional insurance policy. They simplify the logistics of getting optimal nutrition on a daily basis by giving you just one thing with all the best things. That's why I use it daily, as do several of my family members, and we recommend it to our athletes. 1 scoop of AG1 contains 75 vitamins, minerals, and whole food sourced ingredients that work together to fill the nutritional gaps in your diet. They support energy, focus, digestion, and recovery. And this can happen for less than $3 per day and without taking multiple products. While most nutritional supplements come to market and remain stagnant, AG1 continues to obsessively improve this one holistic formula based on the latest research, producing over 50 improvements in the last decade. They invest in the most absorbable and natural source of each ingredient and go above and beyond in third-party testing to ensure that their customers continue to receive the highest quality and best tasting nutrition habit on the planet. Whether you're keto, paleo, vegan, dairy-free, or gluten-free, it'll work for you. It contains less than 1 gram of sugar per serving. They put 75 ingredients through the rigorous NSF certification test to come up with a safe formula that's trusted by some of the world's top athletes, including many of our own at Cressey Sports Performance. Right now, AG1 is giving our listeners a special welcome kit that includes AG1 travel packs and a bottle of vitamin D3 plus K2 when you subscribe. Just head to drinkag1.com/Cressey and claim this special offer. These travel packs are perfect for supporting your immune system, energy, and gut health when you're traveling for games, training, or simply when you're on the go. They can be a great counterbalance to the less than ideal on-the-road food options. So if you want to bridge the gap between deficient and optimal and give yourself the best chance of getting nutrient diversity, head to drinkag1.com/Cressey, Cressey, to get the travel packs and vitamin D3 and K2 with your first purchase. Again, that's drinkag1.com/Cressey, Cressey. You won't regret it. For this episode, we have 2 guests. First, Dr. Eric Wagner completed his undergraduate education at the University of California, Davis, where he lettered for 3 years in basketball and majored in biochemistry and molecular biology. He then completed medical school at the University of Chicago and went on to complete his orthopedic surgery residency at the Mayo Clinic in Rochester, Minnesota. After residency, he was selected to train in the hand and microvascular surgery at Mayo Clinic. Following this year, Dr. Wagner was selected to train in the prestigious Harvard's International Shoulder and Elbow Fellowship at Massachusetts General and Brigham and Women's Hospitals in Boston. He now sees patients in Atlanta at Emory Healthcare. Dr. Wagner's clinical areas of specialty include common and complex pathologies from the shoulder through the hand. He's published over 350 peer-reviewed journal articles, delivered over 1,000 lectures and presentations at national and international meetings, and authored over 25 book chapters. He also serves as an associate professor and director of upper extremity research at Emory. Our second guest, Dr. Robert Bowers, is also a sports medicine physician at the Emory University Sports Medicine Center. He attended Furman University, where he played Division I college baseball and majored in health and exercise science. He then attended graduate school at Auburn University, where he earned a Master of Education degree in exercise science and a PhD in kinesiology/exercise physiology. Following graduate school, Dr. Bowers earned his medical degree from Philadelphia College of Osteopathic Medicine, Georgia campus. He completed both his residency training in physical medicine and rehabilitation and a sports medicine fellowship at Emory University School of Medicine. Currently, Dr. Bowers is director of the Emory Baseball Medicine Program. His perspective, experience, and expertise allow him to serve as a team physician for the Atlanta Braves and the Georgia Tech baseball team. He's also the head team physician for the College Park Skyhawks, the G League affiliate of the Atlanta Hawks, and Woodward Academy. Dr. Bowers serves as an assistant professor in the Department of Orthopedics and the Department of Rehabilitation Medicine at Emory. His specific clinical and research interests include baseball medicine and throwing athletes, sports-related musculoskeletal injuries, diagnostic musculoskeletal ultrasound, minimally invasive ultrasound-guided procedures, and orthobiologics. Dr. Wagner and Dr. Bowers, thank you very, very much for taking the time to chat today.
Yeah, happy to be here.
So I'm gonna apologize in advance because we've got a three-way podcast, so we'll stumble over each other as we all try to talk at the same time. So I'll do my best to address the questions to one person rather than both whenever possible. And I'm also going to apologize in advance because I'm like a little kid on Christmas doing this because this is something that I'm super passionate about. I nerd out about it often, and I think it's a very underserved aspect of kind of sports medicine. You guys are doing some really cool stuff at Emory, and I'm excited not just to learn about it, but also to celebrate the success that you guys are having that other folks might not know of, kind of in the industry. So we'll dig right into it if that's okay with you. So
Yeah,
we'll
sure.
start. Let's talk. Dr. Bowers, we'll go first. Let's first highlight what brought you, and we'll ask the same question to Dr. Wagner afterwards. What brought you to this realm of the sports medicine world? Like, how did you wind up becoming uniquely positioned to manage these new challenges we're seeing in overhead athletes, both in terms of thoracic outlet and maybe more generally this world of peripheral nerve entrapments in that community?
Yeah, I think everything just kind of came together the way, it kind of organically, through playing baseball in college. I always had an interest in throwing athletes and always had a desire to, as I, figured out that I was a very mediocre college baseball player, that I was going to have to figure out other routes to kind of stay involved in the game as something that just kind of gets in your blood. So it was always an interest of mine to, through my path to sports medicine. My primary specialty is physical medicine rehab. We do a lot of neuromusculoskeletal training through physical medicine rehab, kind of an overlap of MSK and neurology. And so we got a lot of training with EMGs. And so kind of this peripheral nerve interest started through that. And then you combine that with my interest in throwing athletes in sports medicine, just kind of naturally went in that direction. And then I think that it just happened, fortuitously that I started at Emory the same year that Eric started at Emory, and he had this interest in thoracic outlet syndrome, and with my interest in throwing athletes, it just kind of happened naturally, and since then it's kind of snowballed, and so I think there is a combination of background and interest and training through residency and fellowship, and then just being fortuitous to start at the same time as Eric, who has similar interests.
Dr. Wagner, what about your route? How did you wind up kind of taking this specific, I guess, niche of the industry on?
Yeah, I mean, so a similar. I was an ex-athlete and had an interest in sort of that extremity through a variety of my own injuries. But as somebody who sort of specializes in shoulder, and one of my sort of passions is like looking into stuff that's a little bit more challenging and a little bit less known. And it actually struck me. I used to listen to the Easy Rider podcast, and Rich Hawkins mentioned that in his career, the biggest success he had was the throwing elbow. The biggest failure he felt like he had as a field was the throwing shoulder. And it's interesting when you think about that. But if somebody who's contributed so much to sort of say that as he's kind of fading out of his career, if you look at it, it is true. Like the throwing shoulder still is a very, very challenging area. And so I think it's like a cool area to think about. And then when you add that to our poor understanding of a lot of the things, especially whether it's throwing shoulder or just overhead athletes and their ability to get back from things like thoracic outlet syndrome or kind of similar types of dynamic compressive neuropathies. It's something that I think we are very much at the sort of tip of the iceberg. And I think there's a lot that we have to learn. And it's something personally that I think is fascinating to think about, the next couple decades. I think we're going to be knowing, thinking, and treating people so differently than we have been the last decade. And it's cool to be a part of that.
And I think we've seen that even happen over the last decade. And we'll talk about that a little bit later, but maybe some groundwork. And I'll send this one to Dr. Bowers. Speaking more generally, for our audience, what makes the upper extremity of a thrower uniquely, I guess, anatomically adapted, in your mind? How is it different than what you might see on their opposite shoulder or, what you might see in the general population that doesn't participate in this world?
Yeah, I mean, I think for the purpose of kind of what we're talking about around the shoulder, and we'll get more distal in our conversation too. I think just as people throw, you get this underlying humeral retroversion, which kind of predisposes the shoulder to external rotation as opposed to internal rotation. And so the soft tissues become more compliant to allow you to pull into external rotation. And then you have some of the scapular mechanics and how we see that differently in a thrower. And so with the thrower, you want to see more kind of upward rotation and posterior tilt through the throwing motion, but the adaptations kind of bring you into more of a protraction. So the chronic adaptations somewhat work against what we need to happen with the scapula during the throwing motion. And so if you take all of these things together, that kind of fits into what we're talking about from a thoracic outlet syndrome standpoint. So if you're taking the shoulder and bringing it into chronic like scapular protraction and narrowing through the front of the shoulder, narrowing that retropectoralis minor space, and then you take a shoulder that is adapted to go more into external rotation, allows you to take those structures through the front of the shoulder, like the brachial plexus, and compress it even more into that space anteriorly. And I think that is really what we're looking at here. We see these adaptations that happened in the throwing shoulder that allow them to perform better, but also you have these chronic adaptations as well, which will predispose to some of these peripheral nerve or compressive neuropathy conditions. And so, it's working for the athlete while also working against them at the same time.
I think you nailed it. Nerves don't like to be compressed and they don't like to be stressed. And I think even beyond that, right, there's a vascular component that we'd be,
Yeah.
unwise to overlook. Dr. Wagner, I know there's
Yeah.
a lot of research about altered blood flow to the throwing shoulder. Like, how would you expand on his response?
Yeah, I mean, it's cool to think like what the body can do, but it's also interesting to think when the body is doing something that's against its normal sort of anatomy, the adaptations that happen, and that's what's hard to understand is when those adaptations start happening. It's not always you can get an MRI and say, "Hey, perfect, this is exactly what's going on," or "Hey, this is an X-ray. This shows exactly what's going on." And so it's that adaptation and that repetitive kind of continued compression or continued the body's response to the hyperextension, that body's response to putting the arm and the shoulder in certain ways. The body naturally, if the gluteal joint's doing something, the scapula is kind of like doing something different. Same thing, honestly, with the neck and the scalens. I mean, you have a similar type of dynamic adaptation that over time, as you do it more and more, you have different neck motions. More and more, it alters the anatomy there. And so, when you look at the nerves coming out of the neck, going underneath the clavicle, underneath the pec minor, and then the vessels coming out of the chest and then going under the clavicle and the pec minor, those adaptations, those muscular adaptations are what's really having the big impact. And that's what's compressing the vessels coming out. That's what's compressing the nerves. That's what's compressing branches of the vessels and the nerves. And that's what's giving us, kind of this varied picture. And I think that's what's so difficult to understand is that there's kind of multiple different muscles at play. There's a scapula shoulder picture. There's this kind of neck and scalenes picture. And then there's kind of different anatomic structures that are suffering as the result of it.
I mean, I think you just nailed kind of how this is so challenging, right? That someone might present with, tingling in a certain aspect of their hand, and you have to go through so
Yeah.
many different areas. For Dr. Wagner, it seems like we've gone from an industry. I can specifically remember a fall 2014 one Major League Baseball team doctor told a player, "I don't believe in thoracic outlet syndrome." And sure enough, this player, 4 or 5 years later had a surgical intervention to deal with, what was a chronic ulnar neuritis that was
Yeah.
actually of more proximal origin.
Yeah.
It's often been called a diagnosis of exclusion. It's something that's kind of an all-encompassing diagnosis for other people where, they see people that maybe, lose a pulse in their hand when they put their arm overhead for 30 seconds. And I'd argue that probably 80% of players probably do that. So like, is this what makes TOS so challenging is that we've had some people that have completely denied it and some people that have said everybody has it. And you guys have just kind of jumped in the middle and said this is much more nuanced.
Yes, without question. I mean, it's funny because if you can't image something, some people just don't believe it, right? And at the same time, others, kind of want to throw something into, hey, this doesn't fit anything else, so let's just call it thoracic outlet and let's just like do a shotgun approach and do everything we possibly can, and hopefully some of these people will improve. And it's sort of not as scientifically rigorous as we applied to so many different other areas, so many different other injuries and pathologies. So I guess my 2 cents is the response to the person who says it's not real. There's very, very good data at this point now. Vascular thoracic outlet, especially where you have blood clots, where you have actual like significant changes. I mean, that's a real pathology that's been treated, and fortunately, in all types of athletes, including major leaguers, it's done really well. When you have a blood vessel that's impacted, whether it's from a muscle compression or the muscle bringing the first rib up to the clavicle, you can decompress that area and you can correct a pathology that you can actually see on imaging. Now, nerve is different because you can't image nerves like you can image the vascular, and I think that's the traditional difficulty with why neurogenic thoracic outlet has had much more variable responses to non-operative and surgical interventions compared to the vascular thoracic outlet because it's difficult diagnosis and it's hard to really understand the pathologic process underlying it. But yeah, I think to answer that question, I mean, vascular thoracic outlet, I think there's a clear etiology, and major leaguers have gotten back to really, really good outcomes after decompressions. The neurogenic one is the one that we are really trying to learn more and more about, and that's the one I think that there is a specific diagnosis. It's these patients are very different than the average major leaguer. That 100%. I mean, honestly, if I raise my arm up, I will lose pulse as well. Maybe that's some of my former athlete adaptations that I just haven't worked through, or maybe it's because I sit at a computer or at a surgical OR and I'm hunched forward all the time, and my adaptations are not exactly the best. But I mean, that's very different than the person who does that and you have, or does the upper limb tension test or does certain things and they have just debilitating pain. And you're right. I mean, so many of these get to us and they've been diagnosed with carpal tunnel, cubital tunnel, whatever else that's a common diagnosis that clearly they have no symptoms that goes along with that, except for they have some numbness, tingling, or maybe some radiating pain. And so it's interesting. I think it's something that we are still learning about, but I do think one of the things that we are hopefully as a field moving towards is trying to figure out what is the main driver to this. Like, where is that compression happening? Is a specific muscle? Is it a muscle group? Like, where is it happening? Because that helps us to actually treat it better rather than just kind of trying to like release everybody's carpal tunnel, cubital tunnel, like infraclavicular, supraclavicular, maybe even like the neck, and just throw everything at it, and maybe something will hit. I think if you can better refine the science and to figure out where it's coming from, that's the golden parachute. That's how we actually really start to understand this pathology.
I love that. I got like 30 more questions rattling on my brain now. You're spinning around, and this is good. So maybe it's a good pivot to Dr. Bowers. So I think I've seen this over and over again is, oh, my nerve conduction tests were all normal. I must be good. And we know that's obviously not the case. In fact, I'd have argued that probably the majority of the ones that I've seen that have gone down these rabbit holes have tested great on EMG studies. Maybe for Dr. Bowers, how has the diagnostic of technology evolved over the last 5 to 10 years to help you treat these challenging cases, particularly as we talk about peripheral nerve entrapments?
Right. And I think really the answer to that question is at the crux of kind of what we're trying to accomplish here with being more specific as far as where exactly these compressions are coming from. And you mentioned previously that TOS has been, or even some of these peripheral entrapment neuropathies have been, or I guess more thoracic outlet syndrome have been more diagnoses of exclusion. And that doesn't mean a diagnosis of exclusion from a temporal standpoint. It doesn't mean you have to go through months and months and months of other things. It just means that we get other tests. So whether that's an MRA of the chest or an MRI of the cervical spine, EMG to rule out other pathologies. So it can be a diagnosis of exclusion there, because so often with thoracic outlet syndrome, your EMG is normal. Your MRI, your brachial plexus is normal. Your MRA of the chest is normal. And that's because these are dynamic issues. So especially in a thrower, this is not a static issue where you can get a static exam and see differences on imaging or EMG. They're dynamic, and that's where what we're trying to accomplish comes into play. And that's as we've gotten more and more advanced ultrasound machines. Like I have a $100,000 ultrasound machine in clinic that with multiple screens on the walls that I can, that I'm able to easily see some of these nerves. And so that way we can then, isolate these nerves and these anatomical structures on the ultrasound, see them very clearly. And this is where the diagnostic injections come in. So we do the diagnostic injection with just local anesthetic around these structures. And so if it's TOS, pec minor, anterior middle scalenes, if we think it's more peripheral, and that could be suprascapular nerve, it could be the ulnar nerve, we could go down the radial posterior interosseous nerve. So really any of these nerve structures we can diagnostically inject around and then have the athlete go throw immediately afterwards. So baseball guys, if they hurt with throwing, if they hurt with lifting, I have them go throw and lift immediately after we do the injections to see if their symptoms are resolved. And it allows us to be a lot more specific in the ability to say this is where the symptoms are coming from, based on their dynamic motions that normally create these issues. And I think that's where we become more advanced with our technologies, with imaging, and then just our understanding and ability to really hone in on specific areas.
This is powerful stuff. I think maybe interesting to see, like, say I'm a patient and I've got tingling in my pinky and my ring fingers, and I come to see you guys. For Dr. Wagner, maybe we'll start proximal and work distal. Like, let's talk about the potential areas of entrapment that are going through your brain as you see me for the first time and talk to me in your clinic. And then, how do you guys have an algorithm for attacking that? What are the most common suspects, and what's the order of operations?
Yeah, the two most common symptoms, as you mentioned, it's either radiating pain kind of into your chest, like down the arm, or it's numbness and tingling in the fingers. And so when you're thinking about either of those, you're going through proximally from the cervical spine. Then you have, as Bowers mentioned, the scalenes, and you have the pec minor, kind of retroclavicular space, and then you have, and then as you move down, if it's more of a shoulder issues, because sometimes people have different radiating shoulder or chest pain, that could be suprachiasmatic nerve, that could be a quadratus space compression, and then as you go down, that's when you start getting into the peripheral compression. Carpal tunnel tunnel being most common, but then you have everything under the sun from posterior or anterior interosseous neuropathies to Lacerda syndromes to a variety of other sort of more narrowing ones, and those become more common in people that are repetitive overhead athletes. That's where you get stuff that's a little bit more nuanced. I do want to give Bowers a shout out and maybe have him expand it a little bit if it's okay, Eric.
Please do.
Botox is something that I did not really think of and did not. I had been told when I was sort of getting into this field that Botox was useless and you shouldn't use it. It doesn't matter. It's not going to help and this and that. And I can say our experience has been nothing further from the truth, because it's a dynamic muscle compression that we're talking about. And you have dynamic cubital tunnel where sometimes, not necessarily baseball players, but you'll have like really strong athletes, like football players, will have a subluxing ulnar nerve because of their triceps are being so big.
Yep.
But Botox is so powerful in diagnosis of these compressive neuropathies associated with this kind of dynamic muscle compression, and it's something that I think, I credit Bowers. He's really pushed, and we've seen some really. It's interesting for both diagnostic and even in certain cases therapeutic. I don't know, Bowers, if you want to expand on how you sort of came about the Botox and how you push that, but it's something that opened my eyes to something that I feel like a lot of people, at least in the surgical field, were kind of not really positive on.
Yeah, I mean, I think it's just about an understanding of where the symptoms are coming from. So I typically am not using Botox as a first line injectate. We're still doing the diagnostic injection with local anesthetic first, and then once we identify those areas of compression based on the diagnostic injections, that's where Botox can come into play. So specifically for our TOS patients who are, we're injecting Botox into their pectoralis minor because they've kind of got this adaptively chronically shortened pectoralis minor, and you try to, if it's already at that point, and you try to get them into PT to stretch that out and work on scap retraction, scap mechanics. Sometimes it's just hard to do without something to help you get to that point. So if we can use something like a Botox to essentially force the muscle to relax, to prime the athlete to do better in physical therapy, I think there's a great utility for it. I think it's more about, again, not taking this shotgun approach, being very systematic in understanding where these nerve compressions are coming from with the diagnostic injections. And then you can use Botox both diagnostically and therapeutically after that, to get kind of longer term results and information, given that it's not going to work immediately. So, that certainly is something that I agree with what Eric said. It has a great role in these situations. I think it's just for those that say it doesn't work, I think it's more about a limited understanding of what the pathology was to begin with, and if we can be more certain based on the diagnostic injections with local anesthetic first, I think Botox has a great chance of being effective.
I think one of the things, I'll speak from my end of the spectrum too, is sometimes all you're doing is you're trying to buy yourself like a window, right? It's very similar to getting manual therapy on a lat or a subscap, and all of a sudden their symptoms go away so that you can actually follow it up with good exercise stuff. And I think a lot of the ones that we've seen, kind of coming in with these presentations, I'm sure you guys have seen a million, rather than having like the good upslope to the clavicle, it's downsloped, like the first rib and the clavicle are basically attached to one another. There's no space in there. They've got these very like military postured shoulders, very flat thoracic spine. And, sometimes you get an intervention like that in place and allows you to get some extensibility through the lat, a little bit of posterior tilt through the scapula, and it just buys you wiggle room to do some great work. So I think, for me, when I hear about Botox, like it's an intervention that's not surgery. That's what makes me excited about it, is
Yeah.
it buys us some time to see if we can fix this.
Yeah, Eric, my colleagues in Brazil had these fascinating 3D CTs they've done on some of these TOS patients, and exactly like you're saying, the TOS patients, the protraction and the narrowing on the front part of their chest, the front part of their clavicle is wild compared to, like, their sitting posture is wild compared to just the average person's, or more normal ones they have. And then when you bring the arm back like this, or you back in extension, or back in abduction and extension, the narrowing and just the compression of everything, how it closes down is wild, especially with how the scapula in a normal person, it would externally rotate and kind of open up normally. In these cases, the scapula, it almost pivots around the coracoid,
Yeah.
and so it creates this really narrow area just right behind the coracoid, right behind where that clavicle is. And so you're exactly right. It's trying to reverse that mechanism where the muscles have kind of altered the mechanics. And that's what's beautiful, I think, about Botox, but that's also what's beautiful about a really good focused therapy protocol, where you can alter that adaptive change. And if you can alter that adaptive change, I mean, and get them to open up, posture retrain, get the muscles kind of better balance, I mean, we've definitely seen really, really nice outcomes outside of surgery. And it's true. It's a true imbalance that's happening, and you can alter that balance and then get them back to throwing or whatever it is they're doing. It's what remarkable the impact you can have. So you're exactly right. It's very similar to that kind of manipulation.
How often, I mean, you guys are more end game, right? This is your wheelhouse. I'm sure a lot of times you get someone who was, undermanaged by their primary care in Oklahoma or something like that. I'm curious, how often when you see something, is it an anatomical variant? Maybe it's a cervical rib, maybe it's an anconeus epitrochlearis, or just a crazy subluxating ulnar nerve that was missed because someone didn't maybe recognize that this means a lot more. Like if you have an anconeus epitrochlearis and you don't play baseball at a high level, it probably doesn't matter. For other people, it could be a very big deal. Do you guys see this, I guess, these anatomical variants? And obviously, there's nerve courses that might be different and impact with this level. But do you see this a lot in your practice where it wasn't caught by someone that was specialized enough?
Yeah. Bowers, you want
Yeah.
to?
So yeah, I mean, I honestly would say for some of these anatomical variants, I don't see a ton of them. So whether it's in Anconius or a cervical rib or anything like that, I mean, they happen, but I can't say that there are a great number of these where the symptoms were missed because of
Yeah.
these anatomical variants. I think it's just about understanding symptom patterns in general, whether or not there's an anatomical variant there or not. So certainly we see people come in that have an Anconius epitrochlearis with ulnar nerve symptoms where they just kind of miss the original diagnosis of ulnar neuropathy or TOS with a cervical rib. But I think it's more about people that have come in and they've had kind of just not a thorough enough workup or lack of understanding of kind of the nuance of some of these issues. And I think that's what we'll tend to see. And even like you mentioned before, where it's a thrower that has this constellation of symptoms, and so whether one of those symptoms is numbness and tingling in the fourth and fifth fingers, and they've for TOS, you'll tend to hit that lower trunk, and they'll have symptoms in the fourth and fifth fingers that mimics an ulnar neuropathy, and the workup has not been as thorough as it should be, and guys come in and they've already had a cubital tunnel release or transposition, and they have
Yeah.
persistent symptoms. So we see people all the time that have already had more peripheral surgeries that come in that it ends up being a more proximal problem.
Yeah.
So I think it's more about that and doing a thorough workup and being able to understand symptoms and the nuance with all of this, as opposed to some anatomical variant was missed. But we certainly do see those when we see people for sure.
If I could give one comment on that, the without question, cervical ribs, I think, and vascular TOS, that's like a pretty well established, and I think that is something that's concerning. Sometimes though we get sent people with cervical ribs saying, "Oh, they have TOS," and it's like just because they have a cervical rib doesn't mean they have
Yeah.
TOS. So it's almost like, oh, we just like immediately saw the cervical rib, and we're not going to do anything else, and we're just going to send them to you and say they have TOS, and that's why X, Y, and Z. The other interesting thing is and I think we're learning this. Bowers on ultrasound with the scalenes is seeing different patterns with the how the nerves kind of branch between the anterior middle scalenes, and then I can say arthroscopically on surgery, I've seen some kind of really interesting patterns with regards to like the pec minor sometimes is like almost cohesive all the way up to the subclavius. It's almost like one massive
Mhm.
motor unit in some of these people, and it kind of goes down into the conjoint a little bit more than it should. And then I wonder if there's definitely some ossified suprascapular or transverse ligaments over the suprascapular nerve that, without question, in a normal patient probably doesn't matter, but somebody who's an overhead athlete, clearly it's going to create an issue. So I think we're kind of at the tip of the iceberg of understanding some of these anatomic variants.
Yeah.
You hit on the kind of common ones, but I bet there's other ones that we haven't actually understood as well that we're hopefully going to maybe better understand as we continue to sort of study this.
I'm
Yeah,
curious
I
to.
think.
Sorry, go
Sorry,
ahead.
that just like you said, we're going to talk over each other. So if you look at the literature right now, there really is no definitive literature as far as the things that I do, the diagnostic ultrasound component of this, and looking at a lot of thoracic outlets on ultrasound. If you look at the literature, there's not really anything that you can hang your hat on to say just from a even dynamic imaging where I can bring the arm into abduction, external rotation, and look at the nerve structures through the area. There's just not something that you can hang your hat on. I'll see things where I'm like, I guarantee you that this is the source of their symptoms based on the way things look. And you do the diagnostic injections, it plays out totally differently, which just speaks to the, how dynamic and nuanced all of this is. And it also, in looking at a lot of these, there is so much anatomic variability from
Yeah.
person to person. I think I think it is going to be difficult for us in the future to pinpoint one specific thing. It's like, if this is abnormal, this is causing a problem, especially going through the scalenes, the way, sometimes the roots, they run through the muscles. Sometimes it's between the muscle. Sometimes there are small, small kind of accessory scalenes that run in there that, could they be causing an issue? Maybe, maybe not. But in the end, it still comes down to how do they respond to the diagnostic injections, because the treatment for those issues is going to end up being the same, whether there's a small accessory scalene or whether the nerve structures are running through the anterior scalene or running through the middle scalene, or whether we see with the pec minor, whether we see bowing, which is essentially when we move the arm dynamically into abduction, we'll see the pec minor kind of bow upwards and see those neurovascular structures kind of press underneath it. And there's some data to say that maybe that means something, but in my experience, I haven't found anything that is reliable. In the end, it's going to come down to, you do the diagnostic injections, how do they respond? And then the surgical or non-surgical treatment for that is going to be consistent.
I'm gonna follow up and maybe take the 30,000-foot view. I'll ask you actually this question of both of you guys. Dr. Wagner, why don't you go first, just so we're alternating turns. But it would be interesting to see what, in your opinion, makes certain people more susceptible, right? Like we have a mutual client who he had bilateral fasciotomies in his lower leg when he was, in his late teenage, early 20s. And he's also had, basically peripheral nerve type issues, thoracic outlet issues, since then. Are certain people more prone to these issues globally? Are there people that they make immature collagen that becomes more fibrotic? How is it impacted by, bad strength training, or a lack of movement altogether? And then also, obviously, we see this heavily in baseball and softball, but we really don't see it very often in tennis players, football, quarterbacks. Obviously, the forces, the volume are different. Obviously, I just vomited, alphabet salad at you. Like, what do you think when you look at people that have these issues more often? Is there some unifying theme across patients?
Yeah, I mean that is the $1 million question. It's something we've actually applied for grants on to
Yeah.
investigate, and 100% that's the thing that I think is going to be something we will understand more. So to take it back to, once again, that 30,000-foot approach, there's without question there's a hereditary problem called hereditary peripheral neuropathy that is very, very rare. So people can have an actual, and there's been a gene associated with that. That being said, there is also, just in the general population, a lot of people who get carpal tunnel, cubital tunnel, and trigger fingers, or some other type of, maybe some rotator cuff tendinitis. And it's like, why do they get all of this, right? And kind of like the on the other end, the extreme of, sometimes people have like very significant compressive neuropathies or very significant inflammatory associated pathologies that clearly there is probably a genetic component that's predisposing them to it that we don't understand. That's a lot more common than the kind of the more rare ones that have been identified. I also think, though, that there's a huge impact on like the epigenetics part, the what we do in life right now. And so I think there's an inflammatory component, and that's probably in part diet related. That's probably in part some genetics, and partly in part of just like how people treat their bodies. And I think without question, we're as we are already understanding more about diet, more about recovery based off of how people take care of their bodies. I think we're going to understand more the role of inflammation, how it contributes to things like this type of peripheral neuropathy or these inflammatory type of problems. And then I think, really boils down to, why is it that a select percent of patients that are baseball players get this? I don't think it's all genetics. I think some of it's just honestly like, yeah, an adaptation, a poor mechanics. They do something that they think is going to make them a little bit better, and that snowballs because of a subtle mechanic tweak that then becomes like, much more. It's this cascade that becomes worse and worse and worse over time. And so I think it's a lot. I think I think there is probably a genetic component to it, but I think a lot of it is actually what we do and how we treat our bodies and our mechanics. And I think that's going to be, hopefully Bowers and I and others that are interested in this type of area, that's going to be something that we can hopefully eventually can contribute, is how do we better, get people to recover in many different ways besides just the surgical treatment of it.
Absolutely. Dr. Bowers, would you add anything to that?
Yeah, I mean, I totally agree with that. I think that there is the primary problem that we can address with a surgery or some other treatment that locally in the area where we're seeing these nerve compressions. But if you take a step back to that 30,000-foot view, what is the foundation that led to this? And like Eric said, I mean, I don't think we're there yet. We can't point to, the athlete you talked about with bilateral fasciotomies, and then he's had all this peripheral, nerve stuff in his upper extremity. I think we're not quite there yet, or not even close to being there yet. But the things in your day-to-day life, like Eric had mentioned, with training and recovery and sleep and diet, all of those things play a role. And then certainly in a baseball player, having that foundation where we can fix the problem anatomically with the surgery, but you still have to go back and create the foundation with proper mechanics, kinetic chain strengthening, all of those things that we understand, just doing a better job with that. And so I think that's the understanding that people need to have going into it.
We interrupt this podcast with a quick reminder that this episode is brought to you by AG1. It's an NSF certified all-in-one superfood supplement that features 75 whole food sourced ingredients designed to support your body's nutritional needs. I use this product daily myself, and a ton of our athletes do as well. Head to drinkag1.com/Cressey and claim my special offer, a welcome kit that includes AG1 travel packs and a bottle of vitamin D3 plus K2 when you first subscribe. AG1 gives you peace of mind that you're covering all of your nutritional bases. Again, that's drinkag1.com/Cressey, Cressey, to get that special offer. I think just... Sorry,
Eric, if we, I just want to say one of the things I think that Bowers and I have discovered and really kind of lean into, and I don't know if it's unanimous amongst people who treat this pathology, is that in our mind, if we do the Botox or if it gets to the point where I'm doing surgery on them, we sort of have a discussion with them. This is the surgery allows them, just like the Botox, allows them to remove whatever that bad habit, that compressive force that has caused them to have these symptoms. But by itself, it's not going to cure them of their problem. And the post-op rehab for this is just as important, if not probably more important than most other surgical recoveries. They're having to retrain how their muscles work. Bowers has a really nice return to throwing, but a lot of that return to throwing is based on correcting sort of faulty mechanics, faulty training habits, and getting them back to what it was like before all this happened. And often that's like 2 or 3 years later that we're getting these people. Yeah. So you're correcting 2 or 3 years of these habits that have been, basically built up. And that is just as important as surgery. And if they can't commit to that and they can't really, dedicate them to that. And now truly, if they don't have good partners that are helping them get through that, truthfully, I'm just not as confident that any surgery, anything that we do is going to work. And it's interesting because you hear and you see and you talk to people, and the post-op recovery is not something that's talked about a whole lot with TOS or with dynamic nerve compressions. Especially when you compare it to like the post-op recovery after ACLs or after slap repairs or after all these other things, and the recovery is talked about so much. It's just, I think this is something that we hopefully are changing that narrative about how important that part of things is. And if you talk to people who've successfully gotten back, I mean, they will tell you that part is just as important, if not more important than the actual surgery itself.
It's interesting. I mean, sorry, good.
Sorry. Yeah. I mean, I know the pro guys, they have access to high level physical therapists that can help them after TOS surgery to kind of get back and fix these things. But if you talk to people on the lower levels, even guys at the college ranks or high school players that have had these surgeries, minor league guys, you frequently hear from them after, so say they have a full thoracic outlet decompression with root resection, scalenectomy, maybe they touch the pec minor or not, is their direction from a physical therapy and kind of return to play after their surgery is almost non-existent for some of these guys. And I've talked to the PTs. I actually had a talk with a guy who works in Tampa for one of the big baseball facilities a few weeks ago. And he basically reached out to me and was like, hey, look, I got a couple post-op TOS guys and we don't know what we're supposed to do with them. The surgeon hasn't told them anything. They're just basically like, yeah, maybe in 3 months you can start throwing again. But there's no direction. And so that's why I think there really needs to be, regardless of the treatment from the physician and who's taking care of these athletes, there has to be some neuromusculoskeletal and understanding of throwing mechanics and the throwing motion and the importance of these things to be able to guide physical therapy afterwards. Because if you don't give specifics, and that's where in the future, all this very individualized kind of data driven rehab is going to come into play. And that's kind of the next step in rehab, and using all of these different things like AI and wearables and BFR and all of these things. They need more direction with that.
Yeah.
And that's significantly lacking in the TOS space as far as post surgical. And again, those are some of the things with Eric and I bringing in kind of a sports medicine musculoskeletal background to this, which you don't typically see in the care of TOS. Hopefully, we can help change that in the future, because they really don't have a lot of guidance from a rehab standpoint after surgery.
I think that's really important because I always, when I'm teaching our interns, our upper intern coaches, big picture, every surgery is either a repair or a removal. And some are a combination of the two. But by and large, the interventions we're talking about are removals, right? It's a scalenectomy, it's a first rib resection, it's a pec minor release. You're not really adding things to the system. There aren't, anchors going in, all this stuff. And I think in a lot of ways, people view it like, you had an osteophyte removed from your olecranon. Hey, 4 weeks and you're on your way. And it couldn't be more further than the truth. And I think if we spin this the other way, I'm sure you guys see plenty of people who had a Tommy John surgery years ago, and then month 11, all of a sudden, all these nerve symptoms were going back. And what we see often are people who just did an absurd volume of arm care during that program, during that rehabilitation timeline, because it was something to fill the time.
Yeah.
And you go and you watch them do a prone horizontal abduction off the table. And they're doing it at 70 degrees of humeral elevation. The scapula is literally stuck to the spine, and all they're doing is they're grinding away into humeral anterior glide during the entire session. They haven't actually activated anything that was supposed to be activated. So we struggle with this a lot, and I love that you guys are highlighting the importance of like the movement competency that goes with it. Otherwise, you're buying them 6 to 12 months until they come back with something completely different.
Yeah,
Right.
100%.
Maybe let's piggyback on that conversation. And for Dr. Wagner, let's talk about surgical intervention for thoracic outlet. What are your clinical indications for proceeding with surgery, and what might that encompass on your end?
Yeah, I mean, I think, and that kind of gets to what the theme of this conversation I think has been. We want to first understand when they first come to us, and we do a battery of a workup, and we have this kind of standardized kind of program that we have because we see so much of this at this point, that we want to understand exactly what's going on. So that's number one is trying to figure out, what are the symptoms, what's really driving this, and then what is the offending mechanism, and that's through the images that Bowers talked about previously, and that's through the injections, and a variety of specific examination maneuvers and other things. So once we've gotten that, and we've gotten to the point where, all right, okay, this person has maybe a infraclavicular, like a scapular girdle driven TOS, or maybe this patient has a neck driven, like a supraclavicular, so it's like really driven from their scalenes, and that dynamic process. Once we've sort of gotten to that point where we have a pretty high level of confidence, and then it kind of goes to, have they sufficiently given it a chance to improve without surgery? And without question, we've seen it over and over again where people have improved. And I think that, regardless whether you just call it prehab before surgery or not, you have to have worked with somebody that's very good, knows what they're working on, and have really committed to this. And so for us, like, if they've not done that for at least 3 to 6 months, we're not even considering touching them, because one, it will prove to us that, like, afterwards they're not going to be as committed to it, and two, we've seen over and over again people actually improve without surgery. And so once they've failed that, and they have fit into our diagnostic algorithm, and we've sort of published on this, but it's basically a response to injection, certain examination maneuvers, and then certain other findings that are negative. Then we sort of indicate them, and one is an arthroscopic approach where it's based on like the suprascapular nerve, the subclavius, and really the pec minor, and kind of opening up the brachial plexus and from a scapular girdle standpoint. Another one is more, you can't do it arthroscopically, but there's an open approach, and that's, I think, one of the hot areas right now that's being discussed on is, who do you need to take out the first rib and do a scalenectomy, or who can you just do a scalenectomy alone with? There's been many sort of recent systematic reviews in non-athletes that say that actually scalenectomies do better than the first ribs for neurogenic thoracic outlet, not for vascular thoracic outlet, but for neurogenic thoracic outlet. Just taking out the scalenes potentially has less morbidity and has a little bit higher chance of success.
Yeah.
And
For those of our listeners who are maybe not as
yeah,
well versed in the
sorry,
nomenclature, I think you would agree the first resection is the aspect of this intervention that probably has the most complication potential, right?
without question.
Okay.
So that's the one that has the morbidity associated with it. So that's the one that has, the first rib lies right on the chest wall.
Yep.
It's right adjacent to it are some important nerves, including one that helps you breathe.
Yep.
Some of the blood vessels going up to your head and going out to your body. And the traditional complication rate associated with that is about 25-30% of pretty significant complications of vascular, of nerve, some other complications. So it's a real there's a lot of risk with that, and there's a lot of morbidity with that, and there's a lot of kind of scarring in that area that I think has made some of the outcomes a little bit more variable. Now, that being said, it's the risk of those if you have a blood clot, if you had something that's involving the artery or the vein.
Yeah.
I mean, I think that is a much higher risk phenomenon that without question merits that procedure. Now, what we're talking about is the nerve. So the nerves come out of the neck between the scalenes, and they actually cross underneath the clavicle, kind of a pretty good distance between the first rib. So although the first rib definitely can contribute to some lower trunk symptoms, it's probably really a scalene predominant compression if we think it's supraclavicular, and that's the idea is that maybe it's actually just the muscle that's the issue
Mhm.
and not the first rib and these neurogenic thoracic outlet. And so maybe just taking out the muscle, which is a safer
Yeah.
and a little bit easier procedure for patients to recover from. Maybe that's all that's needed because if it's
Mhm.
infraclavicular, just taking down the pec minor, opening up maybe the subclavius, maybe the supraorbital nerve, just kind of opening up and taking out some of these offending muscular forces works pretty well. And we've had really good outcomes with it. So potentially a supraclavicular that could be as well. That's something that I think we're still learning about, but it's something that we've been sort of exploring because I think it makes a lot of sense for neurogenic thoracic outlet.
If let's use a case study almost as an example. Let's say a major league pitcher has been managing these symptoms.
Yeah.
They've arm doesn't bounce back well, inconsistent command, sometimes pain, sometimes numbness and tingling. They opt that they're going to do a surgical intervention. If they come and see you the day the season ends, let's call it October 1st, what kind of timeline are you counseling on them for, hey, we're just doing something muscular in nature, we're doing a pec minor release and a scalenectomy versus we're doing the whole shebang with a first rib resection? Who's ready for spring training, who's punting further back, what's the timeline difference between the two?
I'll talk briefly, and I'm going to let Bauer
Yeah,
sort of piggyback off this
sure.
because I know he's really versed in this. I mean, our first thing when we see that person is one, they clearly have had good attention, so they've clearly like worked at this. Two,
Yeah.
they have a timeline that changes things a little bit than those that don't have a specific timeline. Three, our first goal is actually to figure out one, do we agree it's TOS?
Yeah.
Because oftentimes we get these patients and we maybe it's not actually TOS, it's something else. But first, is it 2S? And then if it is 2S, we really try to figure out, is it a infraclavicular, like scapular girdle problem,
Mhm.
or is it like a neck problem? Like what is the offending factor? What's driving this? And that's where, Bowers, I think you can take it from there as far as like
Sounds good.
honing into that before deciding, yes, we're going to do X, Y, and Z.
Take it
Right.
away.
So we'll get to the answer to your question. So I'm going to take one step back and
Sure.
just note the importance of a team-based approach with
Okay.
this. So having a team with orthopedic surgery like Eric on board, someone like me on kind of the non-operative side that does some of the workup, and having a vascular surgery colleague as well that is on board with our vascular surgery colleague is on Dewari at Emory is on board and bought in and sends me the patients to do the diagnostic workup.
Mhm.
And having a team that is bought into this diagnostic algorithm because traditionally it's been a shotgun approach. You have TOS, you have it all taken out. It's your scalenes are taken out, your ribs taken out. Maybe we address your pec minor, and so for us it's all about taking a more specific approach by using the diagnostic injections to determine how much of the symptoms are infraclavicular pec minor driven and how much are supraclavicular driven by the scalenes. As part of our team, we're starting to add in the other aspect, which is just isolated scalenectomy, and that's going to kind of be the next step of our team-based approach, is having that option as well. But I think number one is determining, is this primarily infraclavicular or supraclavicular, because that will determine what surgery is the most appropriate. If I diagnostically block someone's scalenes and 80% of their symptoms go away, and then and also we have to touch on the fact how important it is to stage these diagnostic injections, to not do them all at the same
Yeah.
time, because you do them all at the same time, you don't know where it's coming from. If you diagnose, if you shotgun block the scalenes and the pec minor together, you're going to do shotgun surgery and take everything out. So by staging them, you can really get a sense of how much is coming from above or below the clavicle. And once we have that information, we can then drive them to the correct surgery. And so if we're talking about it is supraclavicular and it is coming more from the scalenes, and we've decided that, take the isolated scalenectomy out of the equation, because I think that's the newer treatment and something we don't quite have as much of an understanding as far as return to play, but we think it would be shorter than the scalenectomy and resection. But if we decide, in some of these athletes that, I feel like some people get the sense that we're trying to dump on, first rib resection and scalenectomy, which we're not trying to do at all. We're trying to just be more specific and isolating where the symptoms are coming
Yeah.
from. And so if they respond more favorably to that scalene block, we send them to vascular for first rib resection and scalenectomy, and they will come back to me afterwards for return to play and return to throw, and I counsel them based on what's in the literature. And what's in the literature currently is about a 10 to 11 month full return to play. So say it's a big league pitcher or a professional pitcher, 10 to 11 months. And there, some of the top vascular surgeons may disagree, but if you look at the literature, it's about 80% return to play within kind of that first year afterwards. And so that is what I will guide them on afterwards. As far as so say we do the diagnostic injections and they get 10 or 20% relief with the scalene injection, and they get 80 or 90% relief with the PEC injection. Because frequently we'll have those situations where we have a little bit of relief one place and significant in the other. And so at that point, we're going to focus on pectoralis minor and an arthroscopic pec minor release with Eric. They do their immediately postoperative stuff with Eric, and then they will start physical therapy within a couple of weeks after that with someone who's well versed with a throwing athlete. And I think the biggest thing that we really focus on are their scapular mechanics, and can we correct the dyskinesis and scapulothoracic abnormal motion before. Once we are able to do that, then I think it's safe for them to start a throwing program. Some athletes get there very quickly.
Yep.
We talked about one guy earlier, and he was moving great at 6 weeks afterwards, and we let him start a throwing program. And so having a surgery at the end of the fall, beginning of the winter, being back ready for spring training is a real expectation in those situations. And so that's where I think kind of this individualized rehab comes to play. But as soon as 6 weeks afterwards, if their scat motion's looking good and the therapist is on board and thinks things are solid and they don't have strength deficits from side to side, then we'll start a throwing program. And so that's where some of this individualized rehab care comes into play here. But when we talk about an arthroscopic pectoralis minor release as opposed to a first rib resection and scalenectomy, we were talking about a significantly faster return to play. Now, that's something we need to do a better job of now collecting all of our data and publishing that so it's in the literature, which we're working on doing. But in our experience and kind of how we've counseled athletes at this point, that is kind of how I'll counsel them as far as return to play and it being significantly faster on the arthroscopic pec minor release side. I can talk more about it as far as how do we determine, how are we so confident in determining whether it's supraclavicular or infraclavicular, and we may get there, but I'll kind of leave it at that for now, and we can get into some of the other discussion.
Well, I think it's powerful too because I think we all know, like, if you do a suprascapular nerve decompression, you see rotator cuff strength improve quickly, right? We've seen people who have a chronic bursitis, they get a cortisone shot, shoulder strength improves. So you might see people that have had a surgery, but their strength, doubles or triples in a matter of 4 weeks just from being able to actually turn muscles on. And I think, anecdotally in my training career, if you can find people posterior tilt of the scapula, good things always seem to happen. We know that people test stronger when they're a little bit more posteriorly tilted when you do their rotator cuff strength test. So you are really opening up a window for rehab specialists to have better outcomes and potentially, to your point, move people a little bit quicker. Actually, I'll punt to Dr. Wagner for a second. And maybe this is another 30,000-foot view one, but injuries have gone up across all level of baseball. And being honest, like, the injuries in tennis are off the charts right now. A lot of people are complaining about the ball has gotten heavier. We see it really everywhere, with respect to shoulders and elbows. I don't think TOS and some of these peripheral nerve entrapments get as much attention, but I do have to assume that you guys have both seen a surge in their presentation,
For sure.
everywhere, but particularly, seeing you guys at Emory. Have you seen that the injuries are actually skyrocketing? Do you think it's that we're similar to what we saw with FAI, like people were diagnosing it better, where we previously might have just called these things true shoulder or elbow? Like, what's your take on the overall incidence and how we manage them?
Yeah, I think that it is getting higher. It's hard. There's a lot of factors probably contributing to that, but I think in general, across the board, it is getting higher. I also, though, do think we are getting better at recognizing instead of just sort of saying, tough it out or whatever else. I think are some of the recognition for just in general shoulder and elbow injuries in the athletes, even wrist injuries, and then you get into the more nuanced ones that like to us and some of those others that are hard to dig. But I think what we found is as Emory slash the people we work with around the Atlanta area got better at recognizing like TOS, we saw a lot more. We just saw a lot more of it, and it was I think being missed a lot. But you could kind of say the same thing about a lot of the other kind of more subtle injuries around the shoulder and elbow that actually have pathologies with them that people
Yeah.
maybe would sort of ignore and miss. And so I think part of this is just in collectively, we're actually getting better as a medical field and a shoulder and elbow field of understanding and potentially intervening earlier than just always treating at the last possible step. But I also think there's been without question there's objectively been a rise in injuries and that's something that's a whole nother topic. But there's a lot of potential reasons for that as well. So I think it's kind of of our own creation, but it's also a little bit of the athlete's creation as well.
Do you think the pendulum has swung too? Like I use the example, you look at internal braces. Dr. Jeff Dugas really pioneered this with respect to the elbow.
Yeah.
And he was baby steps, making sure people were the right candidate for it. And then all of a sudden we saw
Yeah.
every thrower in the country under the sun getting one of these. And Dr. Ahmad Sports Medicine Conference, which I know you're speaking out last year, the collective view across all these team doctors that were on the panel where they're doing fewer internal braces in isolation than ever
Yeah.
before. Are we on the cusp of this? What I don't want to see is a bunch of copycats trying to emulate your work with poor outcomes. Do you think that we're on the edge of that now that thoracic outlet and peripheral nerves are actually commonplace in discussion?
Yeah, I mean, I think we are fortunately or unfortunately, I think it's not quite at that level. There's a couple of reasons for that. I think one, TOS is still something that's hard to diagnose.
Mhm.
Two, it's something that I think we're still learning about some of the variations and some of the subtleties with it. So I think it's the diagnostic part still is a challenge. I think that's one part that I think prevents its widespread adoption at the moment. Two, I do think the surgery is a little bit more challenging than the internal brace or some of the other some of the other surgeries that have really just taken off recently. And so I think that there is that aspect that makes it still some caution.
Mhm.
That being said, I do think that we're going to see a lot more people focusing in on trying to figure out what actually is the pathology underneath it. So I think there's going to be a lot less shotgun approaches as we go forward, a lot more understanding of what is the patient's real problem. What's the muscle that's causing this? What's the area that's causing this? There's secondary symptoms, but what's the primary driver? And that I've seen already that, we have people coming and visiting Emory, sort of observing and trying to understand. And then it makes the surgery, I think, a lot more comforting for people. This surgery, it's a very, very safe surgery. The arthroscopic approach to it, even the scalionectomy, they're very safer surgeries. That being said, there's some technical expertise. It's technically hard enough that I think it's going to be a slow adoption, but I do think, yeah, you're right. I think eventually it's going to be a widespread adoption amongst these areas. But we are still kind of in the infancy, I think. I don't
Yeah.
think you're going to see at Ahmad's meeting anytime
Yeah.
soon people saying, "Oh yeah, everybody's getting a Peckermeyer release, or everybody's getting their skin removed," all that stuff. I think we're still learning about that. And I think until you have a little bit more refined diagnostic algorithm and a little
Mhm.
bit more refined understanding of the pathology, it's going to be at that point when we see more widespread adoption.
I've had a little surgeon bias here, and I'm excited to hear about Dr. Bauer's bag of tricks because I know, we've talked about like localized anesthetic injections. We've talked a little bit about Botox. what else do you have in the, the magic suitcase that you can pull out to help people? I'm particularly intrigued about like your work in researching platelet poor plasma, not PRP, but PPP.
Yeah.
It's an emerging treatment. Like, what else do you have in your sights in terms of orthopedic interventions that are non-surgical?
Right. Yeah. So I think that we're starting to talk about different pathologies at this point. If you go on Open Evidence or Chat GPT and ask AI, I just gave a talk at a meeting last week or 2 weeks ago that essentially was like, you take this pathology and how would you treat it over the last 10 years? How, if you're on the cutting edge, do you treat it today? And how do you see this being treated in 10 years from now? And so it's kind of taken three approaches. And so as part of that, kind of go into AI and ask it, what are some emerging technologies and for surgical or non-surgical treatment, and almost always for whatever pathology it is, it's going to be more evidence-based and higher level biologic injections. And so whether that is PRP and things of that ilk, and then also the individualized rehabilitation where you're using this data-driven individualized rehab plans. And I think that's how we're seeing things change in the future moving forward. And so that's a little bit of what I've been focused on. Now, if we go back and we talk about TOS in and of itself, for TOS, really my mainstay of non-surgical management are going to be the Botox injections. So we're doing Botox based on how the diagnostic injections play out. At the same time, we see plenty of people that have double crush syndrome, where not only do they have compression through the thoracic outlet, but they have suprascapular nerve neuropathy. They have quadrilateral space syndrome. They have I've seen one guy that, we did all these diagnostic injections and he had, scalene driven TOS with suprascapular nerve mediated pain, musculocutaneous nerve mediated pain, posterior interosseous nerve mediated pain. Just his mechanics were all jacked up. And so we had all this kind of shoulder and elbow and peripheral nerve stuff, and we treated all of it. And so from a TOS standpoint, again, going back, I inject Botox into those muscles to force them to relax, to allow therapy to be more effective when you work on opening up the thoracic outlet, and being able to get back to kind of normal scapular motion. More peripherally, I will use more of what's called nerve hydrodissections, and so that is essentially taking larger volumes of injectate and dissecting around the nerves under ultrasound guidance to kind of free it up from fascial plane adhesions and things like that could be compressing the nerve to give it some room to move around. If you look at carpal tunnel data from an injection standpoint, if you can look at three different injectates: saline, corticosteroid, and dextrose prolotherapy. Dextrose prolotherapy is kind of a sugar water mixture that's been shown to be good essentially for nerve health and reestablishing some of the small vasculature to the nerve that's helpful for it. The dextrose prolotherapy is done better than the other two. And so I've taken that. We don't have it for nerves all over the body. It's basically taken that carpal tunnel data and extrapolating it. But that's kind of been my injective choice around nerves. And I think if you ask anyone else around the country that does a lot of these, they've kind of gone to more of a prolotherapy approach to this too, injecting higher volumes of fluid around these peripheral nerves to free them up and give them more room to move around and get basically some healthy fluid around it. I think in the future, as we get more data, we'll start understanding how biologics may be applied here in these peripheral nerve conditions, but we're certainly not there yet. There's some PRP data for carpal tunnel syndrome, but PRP is kind of inflammatory, and I hesitate to put an inflammatory injectate around a nerve that's already kind of irritated. And so if we're talking about PRP and platelet poor plasma, when you separate those components of the plasma, the platelet rich and the platelet poor plasma has a lot of healthy growth factors in it that are more anti-inflammatory. And so in a couple high level throwers that have this recalcitrant ulnar nerve symptoms where they've already had a transposition and they just keep scarring in after their transposition and their symptoms keep coming back, I have used platelet poor plasma to kind of hydrodissect along the length of the nerve through the transposition to kind of free it up. And that very much is based, anecdotally on an understanding of kind of the basic science of it. And they've done well, but those are certainly case studies and we haven't gotten to that point yet. And then, we don't have to get all the way into it, but essentially you ask about platelet poor plasma and kind of my work apart from TOS. My primary interest within the biologics world is on acute muscle injuries in athletes. And so, these acute muscle injuries, we haven't been nearly as successful in preventing these in treating these acute muscle injuries to get guys back faster than we have with other whether it's bony or tendon and ligament issues. And so platelet rich plasma, when you inject it into a muscle, it actually predisposes to fibrosis and scarring of the muscle, which obviously is not a good thing and can predispose to re-injury, which make things even harder. And so what we found on the basic science side is that platelet poor plasma actually leads to muscle cell healing as opposed to fibrosis and scarring. And so that's kind of the biologic injectate we've transitioned to. So now we have cohort studies which have shown significantly faster return to play with platelet poor plasma injections. But now what we're trying to do is start a multi-site prospective trial to show this and show imaging as it tracks and healing of the tissue and not just return to play. And so that's where the platelet poor plasma comes into play. And that's a whole other conversation. But what I will say is I just at the same meeting, that talk that I gave on kind of treating in the future, that's what it was on. I talked about a high velocity thrower, 97, 98 miles an hour with a grade 2 lat muscle injury, no tendon involvement, where average return to play is 6 to 10 weeks, and we did a platelet poor plasma injection into it, and he was back in 3.5 weeks throwing 97 miles an hour. College guy, he got drafted in July, pitched all through rookie ball. I got a repeat MRI on him 5 months post injury after he came back, and there's total resolution of the injury, and he was throwing 97 miles an hour again 3.5 weeks after a grade 2 lat injury, which is pretty significant. And so, that's a case study, and that's where I think we're going with those treatments. And so those are some of the tools in the toolbox, and doesn't necessarily apply as much to the TOS stuff or maybe a little bit to the peripheral nerve stuff we're talking about, because I do think it's more of an anti-inflammatory biologic that we can use to hydrodissect these nerves. But it's certainly not something I'm doing in large volumes at this point.
That's powerful stuff. Do you see an era where platelet poor plasma replaces platelet rich plasma?
No, definitely not. I mean, PRP, we have
Centers.
very high level data for certain pathology, mild to moderate knee arthritis.
Yeah.
Tennis elbow has level 1 data. Gluteal tendinopathy of the hip has level 1 data. Plantar fasciitis has a lot of level 1 data. And so we have very high level data for PRP. So I think it's all about understanding the literature and being evidence based with these treatments and understanding where they apply and where they don't apply. Especially as we're talking about things that are not covered by insurance. You want to try to be as ethical as possible and say, this is what the data tells me where we can apply this. And if you're kind of going away from the data, you just have to let the patient or athlete know that, hey, look, we're doing this. And, one example of that is we've actually seen, me personally, I've had thrower shoulders referred to me for capsular injuries, not huge capsular injury, but capsular strains that can cause pain, or some labrum injuries as well, where we don't have a lot of great data as far as non-surgical injection management. And we've injected those with PRP, and guys have done well. Now, if you look in the literature, there's absolutely nothing on those things. And so I'll probably take my cases and write them up. But again, that's just going to be a case series. But those are things that anecdotally I've seen improvement in throwing athletes. And so you can kind of guide them and say, hey, look, I've treated a number of these, they've done well, but we can't really say that based on the literature that you have an X% of getting better with these injections and being able to avoid surgery.
I love that. So we've been going to an hour, and I want to try to tie a bow on this.
Can I add one thing to
please do.
Bowers, and then just because he's talking about the future, one of the things I think that's exciting about the future for non-surgical, to supplement some of the stuff Bowers was talking about, is the using things like technology like AI, virtual reality, and our ability to better sort of supplement things like Botox or things like injections to also retrain. And so, there's this thing called the shoulder pacemaker, and then there's like biofeedback devices that are ability of patients to kind of get real-time feedback on how they're firing certain muscles and not firing others. There's kind of cool, like Titan Medical has a cool rehab device that allows you to measure sort of not only strength but acceleration as they're rehabbing, and so you can sort of start to see muscle response real time. You can start to see kind of like joint reaction forces real time, and you can start like feeding that into these like kind of machine learning AI algorithms to potentially help us to even better kind of get the body to retrain or to improve the body's ability to recover. And so some of the compensatory mechanisms we were talking about at the very beginning that happen and predispose people to injuries, whether it's TOS or whether it's lat strains or whether it's some of the elbow injuries. If you can sort of if you can in the future use some of this technology to kind of improve our own ability as well as the patient's ability to sort of kind of retrain how they do these mechanics, I think it's very exciting. So we've been sort of exploring some of this stuff just very preliminarily from the virtual reality standpoint, from the kind of the acceleration muscle retrain standpoint. But I think that's kind of the future that we're going down. And I think for the topic of this being TOS or the topic of this being the throwing shoulder and elbow. I mean, that's like where the heart of a lot of this is going to be
Yeah.
borne out is using that technology to give us better data, to give us better understanding of how to how people are responding to some of this stuff, individualizing some of this stuff.
I think I might have hinted at this a little bit earlier, and you said this is the $1 million question, but I'm gonna answer it anyway. Like, I'll give you examples. I've been dry needled probably 20 times in my life, never felt better. But you throw a cup on me and you drag it around, I feel like $1 million for a month, right? We also have athletes who come in, crazy hypermobile people. You give them a good strength training program, and they feel like $1 million for a week. And you have that same program, you hand it to someone who's, big and stiff, and they feel like they've got this electrical charge for 3 days where they don't feel good. They actually respond unfavorably to it. And obviously, this has implications for in-season training for athletes. So I think it goes without saying that the fascial response is highly variable across the population. So you guys are both former college athletes. I'm curious to get your perspectives with this in mind. What causative factors for these injury increases across the board? Maybe we'll go Dr. Bowers first, just because Dr. Wagner just spoke, but where would you attribute a lot of these? Is it that sports are just played faster at a higher level than ever before? Is that kids are specialized way more? Is it, elements of modern training techniques that are creating some of the problems? Where do you think this is all coming from?
Yeah. So I think this is something we talk about a lot, and there's a lot of factors that can go into it. But what I try to do is, again, go back to the 30,000-foot view and say, what's different now than it used to be. And I think it's a combination of volume and intensity. So it's just like you said, like guys are, from a baseball standpoint, guys are chasing velocity sooner and sooner and sooner and sooner and training at high intensities to chase that, while at the same time specializing early and in training to be a thrower as opposed to an athlete. And so we have kids that are playing. Even my son is not even 9 years old yet, and there's already kids his age, like their parents are crazy talking about them. Just they're playing baseball year round. They're playing no other sports. Like he's going to college. And so early sports specialization combined with increased intensity, I think is at the crux of this. By the time guys get to college and the big leagues, I think that ship has sailed. I think their body is primed for injury at that point because they've done all these things. I think unless we make changes at kind of the youth and early adolescent level, we're not going to see changes, very many changes at kind of the big league and the higher levels. So I think things have to change at a younger level in order to make meaningful changes in injury at the higher levels. And that's my opinion, but that's kind of how I interpret the literature and the way that I see things going. Yeah, go ahead, Eric.
No, go ahead. Finish yours.
I think I had another thought, but I forgot.
Okay, I was gonna say. I mean, I would agree. I think that if you look at all across, not just baseball, but across all sports, like the level of athletic achievement is just going higher and higher and higher, and that's starting earlier and earlier, and partly it's specialization, partly it's when they train, they are training for peak performance, not for injury prevention, and that's something that we as they get older and as you get to higher and higher levels, that becomes more and more of a consideration, but less of a but is not really present in a lot of the early athletes. And so I think as you train specifically to get higher performance levels, you're compromising mechanics, you're compromising a lot of things, and you're accepting adaptations that are probably not the best for your future health of X, Y, and Z. And we see this sort of over and over and over again. And earlier and earlier, younger and younger athletes getting these really bad injuries or these kind of adaptations that are predisposing them. And so I really think that's where that's driving it. The level of intensity, the how early everything is. And in addition to our ability to sort of recognize and treat some of this stuff later on, like when they get to college, when they get to the higher levels in the pros, then we understand these problems and potentially try to intervene earlier on them, and that maybe inflates the numbers a little bit. But I do think just across the board, it's that intensity level and that focus of just very, very high performance very early on in people's lives.
What's the closing question? What excites you? I always say, what's the thing that you're staring off into blackness, thinking around, 3 a.m. every night? What's the next frontier for, this industry, particularly in your realm of it?
Yeah, I mean, I'll touch on that, and then Bowers, I'll let you go.
Yeah.
For me, it's just it's understanding the stuff that we don't really understand. I love taking care of people who have problems that we don't really understand, either why they're happening or why they continue to happen or how to solve them or how to get them back to certain things. And so I think it's to me it's very exciting to be able to take care of people that have difficult problems and difficult circumstances and trying to get back to certain things. And then even more so in this day and age, you always hear this, but like being in the field of shoulder is so fun right now because the technology is just like skyrocketing, and what we have at our sort of fingertips to be able to use and to help is we're like just hitting that tip of the iceberg, and it's going to get more and more. So for me, the exciting part is I think over the next 10 years, a lot of the stuff that we have a lot of challenges dealing with now, with the help of some of the really cool technology that's coming out, we are going to be able to get answers for. We're going to be able to improve our surgical and non-surgical options for. And yeah, I'm excited to see how technology is really going to help us to jump forward at much faster rates than we ever have before.
Yeah. I remember what I was going to say. The last point that'll answer your question is that I saw a recent interview with Georgia Tech's head baseball coach, new guy this year, James Ramsey, who's a great guy, and he said something interesting in this interview is that they're not really confident in how a guy's going to develop until they see him at like 17 years old. So for these kids to be specializing in sports before they've really grown and developed in hopes of getting a college scholarship like that, that's way off base. And a lot of these coaches are recognizing, and I think as coaches recognize like, hey, look, we're not going to be really confident as that trickles down to parents. Like maybe we'll see a change in this early sports specialization potentially, if the word can get out that, hey, these coaches really aren't sold on a kid until they're 16, 17 years old, or really they can make a sense of how they're going to develop and how they're going to be able to contribute on the collegiate level. As far as what I'm excited about, one thing we didn't really touch on was, and part of this that I probably should have touched on earlier was just TOS as it applies to the throwing athlete. And so what we've heard about TOS in the past and kind of the traditional approach is like we mentioned before, the shotgun approach is you can diagnostically block all of them, or you just do some physical exam tests and say this sounds like TOS and decompress everything, take out their scalenes and their first rib and their pec minor. So I'm excited about our algorithm potentially becoming more popular and people buying into it more. And so what we found from our diagnostic injection series and doing this on hundreds upon hundreds of people now, we've got a manuscript almost finished that we're going to publish soon on our diagnostic block outcomes, is that, if you look at the general population, it's almost 50-50 of which group does better with scaling block, or 50-50 as far as there's a group that does better with scaling block and a group that does better with pec minor blocks. And so in general, while it's 50-50 in the population, that's more of a pec minor component than traditionally you've heard. And that's probably more, what I find to be probably postural and kind of lifestyle mediated. If you then parse out the throwing athlete component of that, we're looking at more like an 83-17 of pec minor driven symptoms in the throwing athlete compared to supraclavicular symptoms. And that makes sense based on, the throwing mechanics and repetitive internal rotation, you get this adaptive shortening of the pec minor over time. And you talk to many physical therapists or specialized in baseball, they talk about staying on top of the pec minor and how that can lead to that scapular protraction. You have to do the scap work to keep the pec minor stretched out. So narrowing of that retropectoralis minor space due to this adaptive shortening of the pec minor seems to be, from what we're finding out from our diagnostic injection series, seems to be kind of the primary driver of TOS type symptoms in the throwing athlete. And so that then changes the surgery that's most appropriate to an arthroscopic pec minor release as opposed to a big first rib resection and scalenectomy. And so with all of that said, that's part of what excites me, is getting the word out more and more that, hey, look, for a throwing athlete, this big surgery may not be appropriate. If we can really take a more kind of graduated or graded diagnostic approach, a more specific diagnostic approach, and find that your symptoms are more driven by the pec minor, we can save you some time and return to play and not have as big of a surgery. So that becoming more and more recognized in the medical community or in the community taking care of throwing athletes excites me. And then selfishly, as a non-surgical doc, is getting better at treating some of these things non-surgically without surgery. Like what type of interventions can I apply to give athletes a better chance of avoiding surgery? And so in the future, whether that's biologics or better application of Botox to certain conditions, those are the things that kind of get me revved up as we look towards the future.
That's exciting stuff. This was awesome, guys. I'm trying to remain engaged in the conversation when I really want to just be scribbling notes the entire time. So I'm gonna have to go back and give this an extra listen or two. But folks, where's the best place for them to find you? Is it just heading to emoryhealthcare.org, or is there somewhere else they could dig you up?
Yeah, you can, if you just Google my name, it'll pull up my Emory site and just kind of the Emory page, just, Robert Bowers, Emory Sports Medicine, that'll pop up. But then certainly on social media, kind of, I use my old baseball nickname from when I was growing up. They called me Robo, so it's at the Dr. Robo. So it's kind of juvenile, but I made my Twitter handle in 2012.
It's
So,
relatable.
right. So you can find me on social media. As I've gotten more invested in doing more and more academic stuff and got more clinically busy, the social media has kind of fallen off a little bit. Can certainly find me and contact me through social media if any questions.
That's right.
Yeah.
Dr. Wagner, Emory site for you as well.
Yeah, I mean, there's the Emory Upper Extremity site. There's social media, Emory Upper Extremity social media, and then honestly, if people want to reach out, like I'm always happy to give my email out to people. So my email is eric.r.wagner@emory.edu. So anybody's welcome to reach out to me if they have questions. We have protocols we can send them. We're obviously happy to help in any way we can. So without question, we've published a fair amount they want. I can send them a lot of the stuff that we have. We have a lot more coming out within the next year or two that I think is going to sort of help reinforce a lot of stuff that we were sort of talking about in this. And like I said, I have no problem anybody, regardless who they are, reaching out and we'd love to engage them because as you know, this is one of our areas that we find very, very rewarding, very satisfying, and we're hoping to sort of help lead forward in the future.
This is amazing,
Yeah,
guys.
same.
Thanks so much. Appreciate you taking the time, especially on a Sunday. You're doing a great service to many, many athletes, and it's cool to share this to a larger audience so we can help some clinicians as well.
Yep. Thanks for having us, Eric. Really appreciate it.
Thank you, Eric.
Thanks so much for tuning in, not only for another episode, but for another season. We really enjoy these conversations and bringing different expertise from around the industry to you. Specific to this episode, if you are looking to learn more about the etiology, training surrounding, and rehabilitation after thoracic outlet syndrome, I would definitely encourage you to check out my resource, Thoracic Outlet Syndrome Diagnoses and Interventions. If you go to ericcressey.com/thoracic outlet, you can learn more about it. Additionally, we'd love it if you take the time to head over to iTunes and leave us a review summarizing your experience listening to this podcast. Every bit of support helps as we work through this labor of love to support the baseball industry at large. Thanks again for tuning in.